All right, well, it's lovely to meet you all today. My name is Elliot Reed. I'm the founder of the Revitalised Clinic, which is a clinic based in Gravesend, which I started in around 2013 when I graduated. So whilst I was studying, like a lot of you, I studied to be a sports massage therapist and then used that qualification to start to build a bit of a clientele. Now, by the time that I graduated, seeing people door to door with my massage table around the local area, I was seeing maybe about 30 people a month. And I thought, well, that's probably enough to cover the overheads of the clinic, which it wasn't, which I learned very quickly. But then after that, from taking that small client base of 30 people that I was seeing a month, which was an entire patient list of about 500 people, I then took out a lease on the first shop front. Built that into a multidisciplinary practice, so we started to combine osteopathy with evidence-based herbal intervention and personal training as well. And then we built that up to a client list of about 1,500 customers, and we were seeing about 350 appointments a month. And then after that, we then expanded into our current premises, and this is an 1,800 square foot clinic. And now our patient list or client list is 8,000 strong, and we're seeing anywhere between 800 to 1,000 appointments a month. So what we're going to be going through today is how I built that and the philosophy of evidence-based osteopathy, which I feel has enabled us to build such a good reputation that we're now the go-to clinic to go to in our area. I'm very proud to have been elected as an IO counsellor, and my goal as an IO counsellor is to further promote osteopathy and to make sure that we're pushing osteopathy forward the right way and marketing osteopathy the correct way as well, essentially building our exposure as much as possible. Now, the reason why evidence-based practice in my eyes is important is I feel we owe it to ourselves and we owe it to our patients to be the best possible practitioners that we can be. We aren't in a profession where we have the luxury of being just satisfied in how we view ourselves. We will, without a doubt, always be judged by our patients and judged by our patients in terms of our effectiveness, and we have evidence, and a lot of evidence, to really suggest or measure ourselves against as to whether or not we're doing the right thing. But we're going to be talking about how to do that in a second. Now, the reason why I was quite, not concerned, but I was a bit fearful going into practice, wanting to be the best possible practitioner I could be, is that being the best possible practitioner you can be is a lot of the time counterintuitive to business, right? If I could get someone to come a lot more than they actually need to, that actually makes far more financial sense than actually getting them better, right? If I take my ethics out of it. However, I thought that model, which a lot of practitioners use, is immoral, it's unethical, it's ineffective, and it's not something that I could pride myself on doing. I wanted to be the individual, the practitioner who gets patients better, quicker, helps patients to recover quicker than another practitioner. So what we're going to be talking about today is why forming an evidence-based practice is important, how to implement evidence as osteopaths, which is very different in my opinion to how you would implement evidence in, say, an allopathic setting or a traditional, we'll say a mainstream medical setting, and also how to build a business or how to build a practice around that. Right, now, when we look at the principles of osteopathy, i.e. the body is a unit of mind, body and spirit, the rule of the artery is supreme, structure governs function, the body has its capacity to self-heal, these are tenets which evidence is suggesting to us to be actually correct. Right, so the flaw is not necessarily in osteopathy as a philosophy, but what we commonly see is the flaw in the application of osteopathy. We commonly see that it's anatomically reductionist, i.e. that, for example, I could really easily get a really good impression from one of my clinical tutors if I said that, well, yeah, there's a little bit of facetal irritation in the lumbosacral area, and I think this is translating from iliocostalis on the left-hand side, and it's probably caused by a forward protraction of their left shoulder, right? It's all bullshit, but it sounds great. Now, the issue is that doesn't actually hold up true when it comes to the evidence, and because it doesn't hold up true when it comes to the evidence because of multiple factors which we're going to go into in a second, in terms of catastrophizing the patient's picture, you can actually do a lot of harm, or more harm than good, we might say. So we're going to address how we can actually run good practice through our our tenets and through our principles as osteopaths. But the other, I would say, very, very rewarding thing is that being an effective practitioner, according to the evidence, helps us to treat more severe cases. It helps us to restore a level of function that other practitioners might not be able to do. Now, by doing this, it raises our reward as osteopaths because we feel we're doing more good. It raises, obviously, the value that we're providing to our patients, but also, as well as that, it raises the status of osteopathy in general. So we don't just owe it to ourselves and our patients, but also to osteopathy to be the best practitioners that we can possibly be. Now, like I said to you before, evidence-based osteopathy is very different to evidence-based allopathy, or like I said, a mainstream medical model, right? And there's good reason for this. When we look at, say, the NHS was founded at a time where the goal of the practitioner was to reintroduce that patient back into work as soon as possible. A lot of the conditions that they were treating at the time in, say, the 1940s would have been workplace poisoning, workplace accidents, blunt force trauma, i.e. acute trauma that needed very, very specific intervention to make sure that the patient was well because time was running against them. Now, how does that differ to a lot of presentations that we're seeing today in the NHS and in private practice? Are patients coming in with acute presentations or chronic presentations? Chronic presentations, right? Which means that these fundamental principles of the body's own ability to self-regulate, the body's own medicine chest, the body is a unit of mind, body and spirit. These start to become more important because we haven't got an acute fight where that patient needs immediate attention. We've got chronic degradation of the patient in which that patient's body is trying to fight a losing battle. And if that patient has better foundations for their health, then they're far more likely to make a full recovery. But once again, there's no point in doing a good job if we're not going to tell other people about it, which is why in the latter part of the presentation, we're going to be speaking about marketing and growing a practice based on these successful interventions. Any questions so far? All good? All right. So I had I suppose you'd call it a, not traumatic, no, it wasn't traumatic. It was a bit haunting. So I think it was in the second or third year, and a trial had just come out about homeopathy. I don't know if anyone remembers this. It was a random control trial, and they took homeopathy and they tested it against placebo, and they discovered that homeopathy against placebo doesn't really work. There's no significant improvement for patients. And this got me a bit scared. What if osteopathy doesn't work, right? Now, considering at the time osteopathy was considered to not be an evidence-based practice, it further made me want to be as effective a practitioner as I could be, and it made me scared of being ineffective. So I started to apply more critical thinking to my practice as an osteopath. What I found is that there were many osteopaths, including myself at the time, which were relying on anatomical reductionism to explain patient presentations. Now, by doing so, we were completely missing sight of the patient. Just like the example that I gave you about iliocostalis and tension of lumbosacral junction and protraction of the left shoulder, etc. We lose sight of the patient because that patient who I was seeing would have been far more likely to have predisposing factors in their sleep deprivation, in their diet, in their activity regime, how they saw their injury, than my own subjective interpretation of what was going on. I also encountered a few debates, which we'll see in a second, with Edzard Ernst. I don't know if anyone's heard of Edzard Ernst. So, Critique of Complementary Alternative Medicine. Adam Meakins, I don't know if anyone's heard of Adam Meakins, Simon Singh, Ben Goldacre, written a fantastic book. I was conversing with these guys on Twitter a lot of the time in quite an argumentative way, because I was trying to promote or trying to argue that osteopathy was effective, and they were essentially hammering me down every time with their own criticisms, right? Rightly so, because the arguments that I was making weren't necessarily founded in good evidence or good information. However, by going through this, I suppose, introspection, or something like baptism by fire, whatever you want to call it, I was able to better critique my own practice and become a better osteopath as a result. Now, one common thing that we see with osteopathy is an ought, which is interpreted as an is. I don't know if anyone's come across the ought is philosophical argument, right? So the philosophical argument is that many people assume that an ought is an is, right? So I don't know if any of you guys in clinical practice have been told that if you manipulate C3 to C5, it might have an effect on the diaphragm. Has anyone told you that? Or that if you manipulate the area where the is it splenic nerve originates from, that you might have an effect on the liver, right? So I was in practice, and this is a memory which is quite strong in my mind. I was in a practice and a patient turned up with liver cirrhosis, and the practitioner, the student said that I want to manipulate, I think it was T12, because this will have an effect on the sympathetic neural drive to the liver, which will then improve his symptoms somewhat, right? Now we can see here that what this practitioner has done is they've layered multiple oughts. I will manipulate T12, this ought to have an effect on the liver. This then ought to have an effect on the patient's symptoms by some unknown mechanism, or some mechanism which isn't quite grounded, right? Now the issue with this is this practitioner is building their house, or building their clinical reasoning on oughts rather than is. And if we continue to do that, we can start to play into our own biases, and we can start to become very unevidence-based, and we can start to get very uncomfortable very quickly, or into uncomfortable situations very quickly, and ineffective situations very quickly. It's not good for us, it's not good for the patient, but as well as that, it's not good for the reputation of osteopathy. If we play our cards right in the next 5 to 10 years, osteopathy could be a very, very successful form of treatment, very well recognised. And that's obviously because, unfortunately, the NHS is underfunded, there's a huge backlog, the private sector is increasing. We want to make sure that we get on that train before it leaves. But to get on that train before it leaves, we need to make sure that we're effective practitioners. And to be an effective practitioner, we need to build our house on is rather than ought. Now, the misconception that I believe a lot of us make is we have a bit of not an obsession, but a bit of a tendency in osteopathy to go back to the founding fathers rather than build up on what's been left since then. So we'll go back to the Andrew Taylor Still, or the John Werner, or the John Littlejohns to find the answers, right? Now, when we go back to the literature which was written at this time, it includes them and it includes the likes of Sigmund Freud or Carl Jung. There are a lot of oughts. The critical thinking at that point in time wasn't as profound as it is today. It sounds very romantic, it sounds beautiful, it sounds like these individuals are just writing their genius to paper, and then there you get your answer. This is how you treat patients. I remember reading that Andrew Taylor Still treated a patient with some type of sinus issue. I think he dipped his finger into the patient's ear, found the earwax to be dry, said that mucus is the foundation for health, or that the earwax is the foundation for health, applied a few drops of water, and then boom, the patient was better, right? Sounds amazing. If we couldn't all do that. But the issue is that these individuals are human just like the rest of us, and their own biases might have even got in the way of their own understanding of what was going on in their patients. We can't rely on these old books to justify what we do. We need to make sure that we're relying on critiqued evidence to justify what we do. All right. Now, what we've got here is, I found this from 2013, so the year that I graduated. Now, I wanted to include this because I wanted to show you the issues that, or the differences that we have in being evidence-based versus, say, allopathic intervention, right? So you can see Adam Leakins here has linked a review of Edzard Ernst talking about osteopathy. And I asked Edzard Ernst, the studies used involved controlled intervention. Did they include the Beam trial? He said no. Beam was chiro and osteopathy without the analysis for the two, right? So what we've got here is a very allopathic way of viewing research, which is pill for an ill, or changing the pill for a placebo, what had the effect, right? And then what we've got here is I ask why and was it fixed intervention, i.e. manipulation of spinal. So I'm basically asking if the treatment was specific to the individual, right? And Edzard Ernst says he doesn't understand what I'm saying, and I'm saying that the reason why it gets more complex is because when you implement different lifestyles, the same injury might need different management, right? I.e., the context is the patient, not the actual tissue or the injury, which is very different to, say, allopathic medicine. And then eventually he says, I have no idea what you're going on about, which is absolutely fine. But that's the issue that we have with, or that's the difference that we have with being an evidence-based osteopath, is that we use the evidence to form the outer circumference of how we treat, not the arrow. Does that make sense? Yeah, so for example, say in allopathic medicine, you would say that if I inject this area with a corticosteroid or a placebo, what has the greater effect, right? Now, if you were then trying to use evidence as an osteopath, you would see, well, what are the parameters? What are what's the clinical reasoning? What's the evidence for my practice? Well, I know that this patient is, for example, sleep deprived, they don't exercise that much, they're depressed. All these things are now forming the walls, which are the barriers for their recovery, right? And then what our goals are is to build stronger walls or better walls so that patient's health can exist well within that, yeah? So it goes back to the osteopathic principle, what Andrew Taylor still said of find health, any practitioner can find disease, yeah? If that person has the foundations for health, they're far more likely to make a good recovery, and of course osteopathic treatment comes into that, but we can't necessarily test specific treatment interventions for a large group or large population of patients presenting with the same injury, because every injury is contextualized by the patient, not the injury itself. Does that make sense? Yeah? Okay, cool.
So how can we ever get truly evidence-based then if we're always going to be up against those sort of barriers?
This is the nice thing. This is the nice thing. Are we up against them? Because what we're actually now seeing is that when it comes to these presentations, which allopathic models are trying to treat, the allopathic models often are failing. So when we see, for example, put it like this. So paracetamol and ibuprofen, right? Effective for acute injuries, but not effective for chronic injuries, right? When we look at corticosteroid injections, now showing to do more harm than good after 5 years, same as knee arthroscopies. All these things which were actually forming pillars of allopathic intervention are now showing that actually for long-term health, they're not that good. So that's why I'm saying that we make sure that we're extracting evidence from not just osteopathy, but from health psychology, from exercise rehabilitation science, physiotherapy, all these things, and we take them into our practice to help us to form better foundations for that patient's health. Yeah? Does that clarify it?
Yeah, but I think with the sort of research models you've got, randomised controlled trial, this, that and the other, it's very specific models you can work within to prove whether something works or not.
Yeah.
And
absolutely.
when you've got the context that the patient's very complex and all the other things that come into it, pain science as well, it's hard to see how we can then come up with something black and white on paper and then go, actually, there you go, that works, when unless evidence changes to become more biopsychosocial, then I suppose that would be a benefit.
Yeah, I mean, so for us, we have the same issues as the physiotherapists and as the health psychologists, which is where rather than actually looking at intervention, they're looking at predisposing factors, and when you remove those predisposing factors, what actually happens to the patient. So we can see the same thing with, say, dietetics, right? So a patient who might come in with chronic inflammation, they change their diet and their inflammation reduces. We could then take that data or take that study to then apply it to patients who have chronic inflammation, but whose diet is, say, of a typical Western diet, change the diet, does their health change? Now, we are, and this is the other thing as well, that when it comes to evidence, a lot of the time the focus is on osteopaths as evidence, whereas for allopathic medicine the focus is on intervention rather than a doctor. Do you see what I mean? Yeah. And that's a little bit of a harsh place for us to find ourselves in, because we're being judged as practitioners, whereas the others are being judged by intervention. Right, which then actually protects them quite a lot, because, well, if it didn't work, then it's the pill, blame it on the pill, blame it on the surgery, don't blame it on me. Whereas we're actually being judged as practitioners. But I would say that, first of all, I don't think that's right. But I think that the way that we approach our patients, because of the way that we do treat and what we are treating, has to fall into that camp of looking at predisposing, maintaining factors, and making sure that that patient is being protected by their own social situation, their psychology, and by their physiology or biology. Now, there are situations, obviously we see with a lot of chronic pain presentations that sometimes doesn't work, which is fine, but we need to make sure that we have done the best that we can possibly do by the research that's available to us at the time. Yeah?
Mm-hmm.
All right. So, aligning osteopathic principles and philosophy with evidence. Now, we can use osteopathic philosophy within the framework of known is, not ought, is. And what we actually want to do is make sure that we're placing the patient as the hero and not the practitioner. Now, this goes back to patient-centered care. The patient has to be, this is going into how we become better practitioners, evidence-based practitioners. The patient has to be the hero of their story. Evidence shows us that the more empowered the patient is, the less catastrophic their presentation seems, at least to them. The more empowered they are, and the more control they have over their pain, then we can say that their pain will, on average, reduce. It's important that we overcome the patient's barriers and not our own. It's not about us trying to work through the problem in isolation from the patient. It's us working through the issues with the patient. And we can see there's some studies in this which I've linked, which you can send it to everyone else. So there's studies and articles to show that knowledge enables patients to make better decisions whilst working collaboratively with their practitioner rather than it being practitioner-centered. Osteopathic principles align with current evidence. Find health, anyone can find disease. We can see from studies that were conducted in 2018 by Colin et al. That lifestyle can significantly predispose pain. An individual who is suffering from low-level chronic inflammation is more likely to suffer from what they call pseudo-injuries. Non-traumatic, idiopathic in onset, but seems to be related to lifestyle. And this lifestyle predisposes these presentations. And when you start to change the lifestyle, the presentation of these injuries starts to reduce. Chronic pain, once again, is associated not just depression, but pessimism. The more that a patient can have an optimistic outlook on their care, the more likely they are going to have a positive prognosis. This means, once again, stepping away from anatomical reductionism. Think about our patients put your mind in our patient, or put yourself in our patient's shoes. If you've got a practitioner standing behind you, and it's like, oh, this is a bit out of line, or this is a bit stiff, or this is a bit wonky, or that's a bit restrictive. I'm going to do this, and this to you, and then I'll see you next week. It takes the patient completely out of their own management. We want to put the patient into their management. This was an interesting quote that I found from this philosophy of osteopathy by Andrew Taylor Still. So the body is, this under the context of the body is a unit of mind, body and spirit. First, a material body. Second, a spiritual being. Third, a being of mind, which is far superior to all vital emotions and material forms, whose duty is to wisely manage this great engine of life. This great principle, known as mind, must depend for all evidence on the five senses and on this testimony. All mental conclusions are bad, and all orders from this mental core are issued to move to any point, to stop at any place. So what we see here is Andrew Taylor still emphasising the importance of the mind, body and spirit and the balance of them. But we also see that we must, he also explains that and he later explains in this paragraph that we must rely on nature's truths. So not on our truths, not on our own subjective interpretation, but on nature's truths. Now, and this was obviously at a time that A.T. Still was born 28 years prior to the founding father of psychology, Sigmund Freud. So we can see where the world was at that time when it comes to understanding the biopsychosocial model which we now understand today. Once again, coming on to the rule of the artery is supreme. Andrew Taylor Still died 5 years after the discovery of vitamins and minerals. So it questions, well, not just the rule of the artery is supreme, but what is that blood actually carrying? The blood of a diabetic or an alcoholic is going to be very different to the blood of a healthy individual. The body is its own medicine chest. We already have evidence that disc herniations sporadically recover between 7 months to 2 years. That most people, especially most men over the age of 40, have at least a partial tear in the rotator cuff. So we know that the body can still function even if there are structural hindrances or structural abnormalities. getting out of our patient's way. So this is the question that I wanted to ask, is that are we sometimes making our patients worse? Is there an error in osteopathic management of pain? Do we take too much power from our patients? And there's evidence to show that anatomical reductionism worsens prognosis. We can see this from MRI. So if MRIs are done unnecessarily, it can lead, or it leads to an average worsening of that patient's prognosis because they have a graphical representation in their mind as to what's going on, even though it's not related to their actual patient picture, to their symptom picture. This is an interesting study as well. Studies, so they conducted a study where they had two groups. They had 100 in each group, say, and they were both coming in for musculoskeletal injuries. And all they did is they manipulated the length of the consultation and the length of the examination time. One group had a longer consultation time and a shorter examination period. The other had a longer examination period and a shorter consultation. Who do you think had the better prognosis?
Long consultation.
Have I written it down already?
Yeah. I hadn't actually read it.
Okay, cool. Yeah, so the patients with the longer consultation had a better prognosis. There's a couple of reasons for this. First of all, we've got the naturally cathartic experience of expressing ourselves when we're in pain, which has shown to be relieving for pain. The second is that if we lengthen the examination period, we're making that patient start to think, or potentially encouraging that patient to think that something serious is actually going on when it's not. So that's why we need to also be mindful of, for example, when I was at uni, I had a couple of patients ask the tutors, how do we get our patients to stop talking? They're talking too much for the consultation. And retrospectively, looking now back at that, we can see how that is probably going to be quite counterintuitive for our management of their care, because they can experience such a cathartic benefit from actually expressing their discomfort to us. The other reason is that so the study conducted by Roche et al. Showed that consultations provided 78% of the correct diagnosis. So just after the consultation alone, 78% of diagnoses were correct. And obviously it got better and improved after examination and after further testing, but 78% of them were right just on the consultation alone. All right. So, now it comes to the question as to, well, what would good osteopathic philosophy look like? Focusing on the principles of osteopathy. We want to build an evidence-based intervention on osteopathic philosophy that is patient-centered and centered around the biopsychosocial model. Becoming loyal to patient success and not a range of techniques or a range of elements of osteopathy which we feel are important. We want to take our extremely adaptive and flexible philosophy and apply it to patient care, as opposed to more, say, allopathic medicine, which focuses on disease and intervention. And we also want to inform our patients to enable them to navigate their own journey, have adequate knowledge of the biopsychosocial model to guide them, once again being the guide and not the hero of this story. So what we're going to do now is actually put into practice building that house around evidence-based intervention, right? So I'm going to give you a patient, and I want you to tell me your thoughts, right? So it's going to be really brief to start off with, and then you tell me if you want some more information to figure out a good intervention to help him, right? Okay, so we've got, we'll call him 85-year-old, spaced loosely around a patient of mine. So we've got an 85-year-old gentleman. Patient presents with right posterior hip pain. Onset 6 months previous, it's been constant since. It was idiopathic in onset, so there's no actual traumatic cause. Aggravated by walking, doesn't seem to hurt, but it doesn't seem to hurt when walking with friends. What do you think's going on? Or do you need any more questions? What's your differential diagnosis? This is easy. Right posterior hip pain. Hurts when walking.
OA.
Sorry?
OA?
It could be OA, or just hip pain.
Mm.
Yeah. What else? What refers to the hip? The right posterior hip. Yeah?
SI.
Yeah, SI. Got list me a couple other things in the area.
Lower back referral.
Yeah, lower back referral. Discogenic, facetal, whatever.
I thought you wanted conditions. I was
Don't
like,
worry about it. Don't worry about it. Okay, cool. All right. Now, so we've got that, right? No.
Get one of these?
All right, so we've got that. So something around the lower back or the hip, right? Okay, do you need any more information? Go on, tell me what you'd ask.
Not from a sort of functional perspective.
So what about predisposing factors? We've spoken about building our house.
Well, we know his age might predispose him, he might not. Might have some OA issues or other things going on.
Yeah, what else?
Other
Psychosocial.
psychosocial stuff.
He
Yeah,
might
so
be
let's ask-
isolated,
so let's ask
he
about
might
that
not
then.
have family, he might not
Okay,
have
yeah.
a
So
wife.
ask me then. 85-year-old patient, 6 months ago. I can't think of anything that happened. I can't think of anything that I did. I didn't fall 6 months ago.
Was there anything else that was happening in your life at the time?
Perfect. Wife was diagnosed with terminal cancer. They used to walk together. Used to have a really good time. Yeah. Any other questions?
How is your wife now?
She's dead.
She's dead.
She died. Yeah, she died. She died.
Right, okay.
She died.
How has that been for you?
Perfect. I used to love walking with my wife. We used to walk all the time. I haven't walked since. My wife used to cook all the time for me. I haven't been able to eat a good solid meal since she passed. What is now starting to complicate that picture? What's going on?
Nutrition, probably sleep.
Bingo. Yeah, it's funny you say that. My trousers don't fit quite like they used to. They're starting to fall down a little bit. You mentioned sleep as well. I haven't been able to get a decent night's sleep since. Anything else?
Has it affected you in any other way?
I've been having some pretty low moods. I haven't really felt happy since she passed.
Have you got any other family members supporting you at the
I go
moment?
to church. Church are quite supportive.
Okay. Is there any hobbies you've given up as a result of this?
I'd love to go back walking again, but it's not the same since I've lost my wife.
Okay.
Right. Cool? Okay, so we've got something that we can really work with now, right? Okay. So yeah, did anything change 6 months prior? Wife diagnosed with terminal cancer, used to work together, no longer can. Have you noticed any changes to your movement? This is another one. What's it like for you to get up off the sofa now in comparison to what it was like 6 months ago? Oh, I struggle. I make all the kinds of noises under the sun, and it takes me a while to get up when it didn't used to. What's that indicating? You alluded to it.
No, somebody else did, but probably OA.
But not just OA.
So.
If you've got a nutritional deficiency, if you've got a caloric deficiency, then you're more likely to suffer from atrophy, right? Atrophy is a predisposition to osteoarthritic pain. Shows that, for example, runners, you could have two groups of runners, runners and then non-runners. The runners will be in less pain with the same level of arthritis than the non-runners. Yeah, so muscle mass helps us a lot. You've obviously got the endorphins from socialising and from walking, which aren't presently there. So we can now see that we can start to build our house, right? We've got depression, we've got sleep deprivation, we've got pessimism, we have atrophy. So then now that we've got these predisposing factors to these individuals' health, what do we do about them? Do we know if there are evidence-based interventions to improving his sleep? Is there some support circles in the church that he can go to? Are there some very basic exercises that he can do which are rewarding, which are going to get him walking again? Are there groups which he can go to help him to get back into that lifestyle which was benefiting him? We haven't even put our hands on the patient yet. Yet just by us doing this, we have probably, in fact, statistically, have contributed far more to his recovery than our hands ever could. Yeah? And this is what, in my opinion, it's about being an evidence-based practitioner, being as effective as you can and making sure that you're seeing that patient, not just feeling that patient with your hands and coming up with a completely subjective interpretation of their presentation. Yeah? Okay. Right, so on to building the patient list. So first, do you have any questions before we start? Yes.
So in terms of like talking to someone where you think the psychosocial aspects of their life are really playing into their pain experience and stuff, I've had it in the past where an osteopath has said to me kind of asked me the same question, like, is there anything going on around the time that your pain started? And I'd kind of like had gone through a breakup or whatever, and he was basically like, well, that's it, it'll get better on its own, I can't find anything wrong. And
what do you mean?
Well, that's just kind of what his diagnosis for me was, like, there's nothing wrong with me.
Time will sort it out.
Time will sort it out, like, you're fine. And that wasn't my interpretation of what was happening at all.
What was your interpretation?
I'd been doing like a lot of like kind of martial arts and stuff at the time, and just like wax kind of my head or like crick my neck or whatever. And I felt like it was this is me. And I felt it was like a musculoskeletal. I really felt like it, but he couldn't find anything in his test to indicate that it was. And I think that experience has really put me off kind of even bringing that up with a patient.
100%. So the reason, so once again, who had the power in that situation? Was
Yeah,
it you
he
or the
did.
Exactly.
100%.
So in my opinion, the better way to go about it was, can you tell me what happened around that time? And you said that you had a bit of a nasty breakup, did you say? Like, do you notice any trends between your mood and your pain? Do you feel like your pain is contributed by your moods at all? No, not really. I keep hitting my head when I do martial arts. Oh, okay, fine. Do you know what I mean? That's you. You've taken me on that journey. Once again, I'm the guide, right? So you've taken me there. You've told me where to shine that spotlight. So that's where we go. The patient. The reason why it's called a consultation is because it's a conversation between two experts. The patient is always going to be an expert on their experience, and it's very, very important that we take them up on that. We can't. There's no way that I could have a patient with severe mental illness, and there's no way that I'm going to argue with them that their mental illness is causing their pain when they insist that it's not.
I was just going to say, it can be quite a difficult conversation when you feel that there might be psychological things that are going on, and you're trying to get your patient on that educational journey, and you're alluding to them that it might be psycho-related. They can get quite defensive, and you can really lose their sort 100%. Of rapport in 5 seconds flat if you don't word it the right way.
You've got to time that dance, right? Because you're coming forward. If they're pushing you back, then you go back. Now, the way that I would approach that is, once again, do you feel like this is contributing to your symptom picture at all? Right? And they might say no, straight up no. And it might be that they just don't want to talk about it. And then I might say, well, okay, no problem, we'll leave it there, but just to let you know, statistically speaking, low moods and sleep deprivation are likely to contribute to someone's pain. If you want to talk about that further at any point, just let me know. And then at that point, they might, well, how does that actually happen? Well, the body's got its own defense mechanisms, right? The brain is about 70% inhibitory. So 70% of the brain is there not to make you feel things. So for example, you don't hear the traffic outside, you don't hear what's going on there, you don't hear the noise from the projector, because your brain is trying to get you to focus on me. The issue is that when we're sleep deprived or we're depressed, we feel the world a lot more. So things can hurt more than they used to, or than they otherwise would. Yeah, and then just leave it there. If the patient wants to continue on that journey with you, then they can do. But that will take time, just developing your communication skills to get that across. Yeah? Any other questions at all?
I don't know whether you've had any psychology training in the past.
I love reading. I'm very fortunate that we have a team of with a clinical psychologist and a counsellor. So I'll always be kind of bouncing ideas off of them. My go-tos, I am a bit of a sucker for the old books. I did like reading Carl Jung and Sigmund Freud. I love reading about the concepts around the hero story, which is a kind of combination of psychology and mythology. I obviously don't implement that into my practice, but it gives me an idea, or gives me a framework to work with, that the patient's the hero and I'm trying to get them to where they want to be, right? Rather than me be the hero. But books on cognitive psychology, motivational interviewing, I find really good. Yeah, really effective.
That's where you've got your basis from, because I would be very hesitant about, you know, I might be able to adopt language that gets me there, but after there, like, where would I go after that? And if someone opens that gate and wants me to come towards it, I'd be like, well, I can't.
Of course. So that's when, and it would be very, and it's possible this can happen, right? And this is always going to be down to patient discretion, right? But at that point in time, if you were to reflect to that patient what you've heard and what they've said, and you say to them that there don't seem to be many mechanical triggers for your pain. In fact, your pain seems to be more related to your moods and how you're feeling than mechanically what's going on. Have you ever thought about speaking to someone about this? And if they say, no, I'd rather just talk to you about it, then fine. That is that patient's choice. Their patient might not be ready yet. And as long as that patient has made that decision that they want to continue seeing you for treatment or for reassurance or for communication, then in my eyes, that's a fair deal. That's something that you haven't manipulated them into doing. That's something that they come up with on their own accord. But I would say knowing your own barriers and limits is very, very important. And you've quite clearly shown that you can do that. And I don't think there's an issue with that.
Regarding sort of opening up that sort of box on people if they want to express themselves or not, do you feel like over the years you've gotten better at communicating and sort of opening that up, or do you feel like you're getting better at sort of understanding when you can go that route with patients? Does that make sense?
Yeah, both. 100% both, because you know, when I graduated, I was 21, 22. So for me, as a 21 or 22-year-old, to speak to a 50-year-old person, 50-year-old patient about their life experiences, quite difficult, right? Now that I'm 30, I've got a lot more experience and I've read a lot more and I've seen a lot more patients. So I'm far more comfortable at doing that. And I'm more knowledgeable about how to guide that patient through those avenues right now. And also remember that our patient's goal, if they are often presenting with, say, symptoms of mental illness, is not to eradicate their mental illness, because they're seeing us as osteopaths. Their goal is to get, most of the time, pain-free, right? And you can get a patient pain-free even if their mental illness is still underlying or still they're managing it well. If they want to specifically address their mental illness, then they can go to a professional who is within that realm. Yeah. So even though we're speaking about the biopsychosocial model, and I'm probably going to bias it more towards psychology because I find it really important. I think it's an incredibly important part of pain management. It's not our goal to make sure that patients are psychologically healthy. It's our goal to help patients become pain-free within the context of their own psychology. Yeah. Any questions?
Sorry, just one more from online. Yeah. So it's just about the case study from before. So would you say that the hip pain was an unmasking kind of prodromal feature of an emotional trauma? Is that how you would phrase it?
No, I would say that, I would say, in fact, read that back to me again, please, as well.
Would you say the hip pain was an unmasking prodromal feature of emotional trauma?
See, that's not something that I could, and this is the reason why, that's not something that I could diagnose, and it's not something that I could clarify, and there's multiple reasons for that, right? One is that I am not going to be the practitioner who helps them to resolve their own mental anguish. Therefore, I'm not going to be able to say that once this patient met a psychological resolution, their pain also went. So I would be more like to say that they have some, and you could use osteopathic or what are they called? Physiotherapy. There you go. You can physiotherapy or osteopathic terms of higher centre facilitation, or you could use higher centre sensitization. But I would say the best way to describe it is that the defence mechanisms are down. What keeps them healthy and keeps them tuned into the world at the moment is at a bit of a deficit. It's not functioning as well as it should. So I'd put it into that context. Yeah, you can still argue, like tissue causing symptoms, still test it positive for a Fadir and a Faber test for hip pain, but you just want to make sure you put it into the context of their presentation. Yeah. Any other questions at all? All good? All right. So, how to build a patient list. So, the reason why I wanted to go through this first is that, put your hands up if you think you're going to start up a practice as soon as you graduate. No? Okay, awesome. So this is far more applicable for you, right? Now, this is the nice thing, that getting new patients is super hard. But when you get them, you want to make sure that you do your best with them, right? Now, what this means is that when you go to work in other practices, those practices now become your sandboxes where you can experiment and you can measure. And what I would very much recommend that you do is you obviously measure patient success, measure how quickly your patient is getting to where they want to be. So one question that we ask is, if you were at 0 when we first saw you and 10 is you at the end of the process, where are you today? Now the reason why we use that, as well as say a VAS pain score, is that that patient might have goals which are outside of just pain. Might be they want to get stronger or healthier, etc. So that's a better way to guide you through that. And you then start to be able to assess your effectiveness as a practitioner. The other thing is obviously measure your rebook rates. Measure how likely out of the list, or how many people out of that list are going to rebook in with you. And I would say that us as evidence-based practitioners at Revitalise, we aim for about 75 to 85%. So 75 to 85% of our patients are rebooking. That is whilst making sure that we're ethically correct and we're only getting patients booked in if it's necessary, right? But what that means is that if you want a patient list of 10 people a day, then you need around 2 to 3 new patients a day to make sure that you're keeping up with your churn, yeah? So, a few tips, and these are the checklists that we go through at the clinic if ever a practitioner's continuation rate drops. So first of all, is, are you using a confident and assuring tone? It's quite common in the clinic, true to. So basically, what I think is going on is this, and it's like it's not going to put the most faith in the patient, right? You want to make sure that you take your time, you've got a confident and assuring tone, that you talk to that patient as though you would want to be spoken to. You also want to try minimize doubtful language, like maybe, like, kind of. These things don't offer certainty to the patient. A formal introduction quoting qualifications at the start of your interaction. Hello, my name's Elliot, I'm an osteopath, nice to meet you. Now, evidence has shown, they conducted some surveys and it showed that by us even having our qualifications on the wall, the patients are more likely to do their exercises, just because the patient sees you as more of an expert. If they see you as more of an expert, they have more faith in you, they'll have more faith in you to continue that journey, right? You want to explain everything. Express your clinical reasoning to that patient the whole time. The reason why I'm asking this is this. I'm testing this because I want to check for this. We're doing these exercises because this is happening, we want to correct this, right? If you're explaining yourself as you go, the patient is more likely to see the value in the intervention, yeah? Right. The other thing is recommending an appointment rebooking time, all right? So one thing that we see is if a practitioner's continuation rate is dropping, a lot of the time they turn up to the clinical coordinator or the administrator, and the administrator asks them, are we booking you in again? And the patient doesn't know when they need to book it back in for, right? They're not involved in the plan, they don't know why they need to come in a week or 2 weeks' time, but it's important. You want to retest at each appointment with either a functional test or an orthopedic test. You want to measure progress as you go. Don't just take the patient's word for it, because it might be that they have completely avoided all the things which were causing them harm before. They say that they're comfortable, they then leave, they go back into playing football, they go back into doing what they were doing before, and their pain peaks and they don't tell you about it because their pain's worsened, right? And there's obviously it didn't work then. So you need to make sure that you're testing your patients as you go. You want to also use your clinical reasoning for your follow-ups. Tell your patient why you want to see them in a week's time or 2 weeks' time, and obviously making sure that you're ethical in your decision to get them in. Now, the other thing that we do is we ask the administrator page to follow up the day later after their first appointment and just ask them how they got on and give you some feedback, right? If they're like, John, it was brilliant, it was great, then send them over a link to write a review and make sure that you ask them to mention your name, and then your name will appear on the, say, the Google or the Facebook reviews on that practice's Google or Facebook listing, right? And what you can even do is also send them a template to, so they know exactly what they need to say. Yeah.
So if they're unhappy, you don't get them to review.
So if they're unhappy, then that's an option for feedback, right? What were you unhappy about? Is there any way that we can improve our practice? So then you can improve your practice and even your, I suppose, your clinical skills based on their feedback. So I would say we haven't had many negative reviews at all. I mean, we rated 5 stars on Google. We've had about 120 reviews, I think. We've had a couple of, like...
Can't please everyone.
Sorry?
Can't please everyone.
There's that, and some people just have crazy expectations. Like I had a patient who came, who wanted to book in, he said, I've got really bad back pain, can you see me on Sunday? I said, well, the only practitioner we've got on Sunday is our physiotherapist, come in and see him. But is he the same as an osteopath? Is he going to get me better? He's going to make sure that he does everything he can within his remit to make sure that you're as comfortable as possible by the time you leave, and he will follow the same strategy that we do, but they don't manipulate, right? Turns up, and he, throughout the whole treatment, he's saying, well, this isn't what my last osteopath did, this isn't what my last osteopath did, blah, blah, blah. Leaves, gave us a 1-star review on Facebook because, or Google, because he wasn't better within one treatment, right? Yeah, it's quite unreasonable. Now, I was quite angry, I was quite upset. I was gonna unleash on him on the Google review. Thankfully, I went to jiu-jitsu first. I left feeling a lot better. I gave him a call. I said, thank you so much for taking your time to leave your review. I'm so sorry that you didn't have the treatment that you expected. And it was probably out of my haste in trying to help you that I didn't get you booked in with an osteopath, and I hurried to get you booked in for a physio, and I'm so sorry for that. I tell you what I'll do. If you take that review down, I'll refund you for the cost of your treatment. So that's what I did, I think about a couple months ago. And the reason for that is I don't want anyone's doubt when they're looking at our Google page that, oh, they're rated 4.9 after 120 reviews. The only bad one is this guy who said he wasn't, and then they'll look elsewhere and then they might go elsewhere.
They always judge you on the bad ones.
Yeah, of course. I want a solid 5-star rating. No doubt we're the best to go to. Yeah, that's my mindset. So that to give him his refund was like, it was. I'm happy that I went to jiu-jitsu first, but it was a no-brainer. No-brainer. All right. Any questions on that? How to build a patient list? All good.
So you obviously started the clinic straight out of uni.
Yes.
Did you ever work for anyone else?
No, I didn't.
Okay.
No.
Don't worry then.
Yeah. Well, what's your question?
I was just going to see like how obviously it's very different starting going into a clinic that you've built from on your own versus when you're working for someone else and you kind of have more help, I guess, building up that patient list.
Yeah, so this is the interesting thing that I get from a lot of my colleagues who have worked with other people, is that they don't get the support they expected. So as part of what we do at the clinic, we involve mentorship. I take responsibility for bringing new grads up to scratch, CPD. I take responsibility for marketing, for building their patient lists up, right? So for me, if my practitioners have empty blocks in their day, if they've got more than say 30 minutes to 60 minutes free in their day, I'll start to panic and I'm like, I need to get that filled, right? But that's the burden I put on myself as a practice owner. But there's a lot of practice owners, as far as I'm aware, that don't necessarily do that.
How do you start building your patient list? How do you find patients?
Have you asked?
Well,
that's what we're going to do now.
Oh, good. Get my pen.
Yes.
Can I ask you just, was there no doubt in your mind? Did you always knew you were going to start straight away with your own?
I did, and it's probably because I think it's just in me. Like, I come from a boxing background. I like a fight, and I wanted to get my teeth into it and just try myself out. That's literally what it was. Yeah. That's all it was. I had a small following because I was doing sports massage at the time. So I was seeing 30 people a month. So I was probably turning over about £900 to £1,000 a month, and the overheads at the first practice were about £1,500 a month. So including everything. It's quite low still, but I was still on a £600 deficit when I first started, and had to gradually build that up. My mindset, and this is especially after being kind of sucked into a lot of this ridiculous hustle culture that we see on a day-to-day basis, is that you want to spread your risks really wide and see what actually works. So I wouldn't go all in on anything. I would try working at a couple clinics and try build your own list at the same time, see which area is buzzing, see what you can, and you can gradually negotiate your path forward, as opposed to going all in on one thing. You then accumulate loads of debt. It's then going to knock you back the other way. Then you've got to work really hard to get back up to where you were before you even started, and then you've got to do it all again. So I'll definitely recommend diversifying your risk as much as you can.
Did you ever regret like not going through any kind of mentorship yourself?
I like to read, so I've read a lot of books on business and copywriting and marketing and things like that. So in my mind, I was able to extract a lot of information very quickly, very cheaply from books. If I was to pay a mentor, what, £100 per session, 4 times a month, £400. Imagine how many books I can buy at £400. But that's the way that my mind works. I don't think I needed bespoke advice because I could navigate that myself, and I don't feel I needed that supporting hand to.
But in terms also of like continued teaching in osteopathy specifically.
Oh, no, interestingly not, because I feel that. No, it was fine, I felt like that, but by the time of my last year, I was like, I'm ready to test myself with patients, and every patient who didn't have as good an experience as I would have hoped, I really took that on myself to figure out, well, what might have happened. Let's go down into the predisposing factors. Is there any evidence to suggest that I might have missed this, this, and this? I've had some pretty hairy times with patients, especially in my early stages. I remember I was talking to my colleagues about this earlier. Actually, I had a police officer who came in, and I saw him for 4 sessions, I think, and I was measuring his progress. About 70% recovered on the 4th session. Then didn't hear from him, and then I sent out a mass email and I said, can anyone, if you had a good experience, write me a review. If otherwise, give me feedback. And he said, well, I was going to give you a stinking review, but I decided to give you some feedback and said, this is what I think. Your treatments didn't work. The exercises didn't work. So I said, I'll tell you what, I'm trying to be the good guy. Come in for a free treatment, and we'll see what we can do. Because I read out his notes and said, well, here you said you were 70% better, and this was after this is after 3 treatments. You're 40% before. So what's happened, right? And he's a bit of, obviously, he's not a nice person, but he got up and he said, it feels like this in my neck, and he got my head and he started rotating it like that, right? So quite a strange guy. So then I get up and I see him in the treatment area, and he walks up to me with his chest out, cinemaizes as a police officer. I don't know what he sees in me. And he puts his chest out to mine. He said, I want all my money back for all the treatments that I've had. So I asked him, okay, let me ask you this. Did you take paracetamol and ibuprofen when you were recovering from this injury? He went, yeah. I said, did it work? He went, no. I said, did you get your money back for that? And he went, no. I said, well, you're not getting your money back from me.
I like that one liner, I'll save that one.
I said, you pay for my time and you pay for my expertise and my effort. You're not paying for results. I've got here that you're 70% recovered. I said, if you want to go see someone else, you're more than welcome to, but that's not how this works. And then that was it. Yeah, that was it.
Can't believe you rotated your head.
Yeah. Tell me about it. Anyhow, all right. So
you must be an osteopath himself.
Yeah. Oh, sorry. Yeah.
No, I just wanted to check. Like, do you have any sort of background in any sort of business or anything like that? Because obviously there's a lot of hassle that not just treating the patients, but when you're starting your own sort of like that as well.
Yeah. So I don't. I have a few friends or a few family friends who have businesses, and they kind of gave me templates and things like that for the profit and loss sheet and for financing and things like that. And that was, I suppose, that helped with the skeleton. But in terms of putting the flesh on the business, that's something that I did myself. Now, I'll be brutally honest. And even now, I work like anywhere to 60 to 70 hour work weeks, which it's not for everyone. I completely understand that, right? It's not for everyone. But I love what I do. I love the grind. I love trying to put effort into something and seeing what comes out on the other end. But that's just me. That's the way that I've always been. And it's understandable in my eyes that that's not for everyone. And I wouldn't, if it's not for you, then I wouldn't expect yourself that of you, because you'll have many traits which I don't have, many traits that other people don't have. I think you should stay true to your nature.
But did you ever sort of stop yourself and realise that you're not actually getting as much time with the patient because of sort of running a business?
No. I'd always prioritise seeing the patient until I thought that I could grow the business more if I didn't see as many patients. So what that then did is got an associate in, and then made sure that the associates were booked, and then I become the overflow, not the associate. I had this conversation a little while ago with another person who was buying a clinic, an osteopath who was buying a clinic, and they said that I'm going to bring in an associate, and they're going to then be the overflow for this excess, right? You can't do that, because overflow fluctuates over time, right? You need to make sure that associate is fully booked and you're the overflow, because then you're going to build loyalty. You're going to make sure that practitioner is getting as much patient time as possible, which is what they signed up for, and then you can focus on growing the business, right? Now, when you work on growing a business, it is not straightforward. It is constant experimentation and focusing on the process rather than the outcome. Yeah, so you're going to get your head down and you're going to try social media, paid advertisement, pay for clicks, affiliation, banners, paid marketing, whatever you like, and then you're going to see what works, right? Most of them won't work, but you'll find 1 or 2 things which work and actually get a return on investment. So for us, we'll talk about that in a second, was social media. So as soon as we started to invest in social media, we were getting a 10 times return on investment. So if I put £1 in, I've got £10 of turnover out of it. So there's a very scalable way for us to actually build our practice. But that took a lot of experimentation and a lot of time developing the skills needed for, say, videography or copywriting to be able to do that sustainably. Yeah. Did that answer your question? Did I go about that in a roundabout way?
That was good.
Oh, okay, cool. Any other questions?
Yeah, sorry, I do have another one. When you first started, were you just kind of working as a solo practitioner under your name, or did you brand it as Revitalised from the outset?
Yeah, so I branded it as Revitalised, and this is actually a bit of advice that my friend's brother gave me, is that if I branded it under my name, I'd never be able to walk away. And I'm very, very happy. I'm really happy. This is probably one of the things that I'm happiest about, that people ask for Revitalised and they don't ask for Elliot that often. Because I only see about 20% of patients now, or 20% of appointments is by me. So the clinic is 5 times bigger than my input, which is I'm happy about. Yeah, it means that but that you have to make sure that you've got a culture which runs through all of your practitioners to be able to do that, in my opinion, because otherwise they would be seeing me, because as soon as they see someone else, it's a bit different. So you need to make sure that that culture runs through the clinic. Yeah. Any questions at all? All good? Yeah. All right, sweet. So yeah, I think we've got I think it's 12 members of the team now. So yeah, so I'm only a small aspect of it. Okay. Right. So. All right. So this is me starting off. That's me starting in my mum's living room. Then we've got a 100 square foot clinic, and then we've got our 1800 square foot clinic there. Right. So this is whilst I was studying, and then that's kind of like from there to there that's a 4-year journey, and we've been in the current practice for 4 years, right? All right, so these are some tips when you're looking for a clinic. First of all, is how do you value the premises that you're looking for? One is, what is the exposure to the street? We can see here that this clinic has huge exposure to the street, right? That means that this is now a gigantic advertisement for what we do. However, the clinic was only 100 square foot, so it only went back a little bit, but we've got a lot of frontage to help to publicise it, right? We also want to look at the footfall, or how many cars are driving past. Now, what I would do is, there was a wall opposite this clinic. I sat on the wall during rush hour, and I just took out a note, and in a minute, I would just time how many people walk past and how many people drive past. That you can then use, so what you do is you divide the rent by that number of people, and then you've got the exposure per person, or the cost for exposure per person, right? That makes sense? Cool, okay. Parking is another one. People tend to be lazy, and people obviously don't like to walk very far if they're in pain. So can they get to you very quickly? We're actually now on the high street, so it's a pedestrianised area. The reason why I wanted to be there is because most people in Gravesend can name every single shop on that road. So I knew that it was going to be in people's memories if they saw something different, and when they do see us, they'll be able to remember us, right? Because it's a common area to go to. Does that make sense? Yeah. Okay. Sweet. And also, you want to be near shops with a similar clientele and a high footfall. So if you are targeting patients who are, you might say, who have a bit more dispensable income, you're probably not going to put them next to the same chain of shops where you see fast food takeaways, right? But if you're near yoga studios, or if you're near lawyers or solicitors, places where people go when they need to spend a significant more amount of money, then that's going to be a better place for you to set up your practice. All right. Also, bear in mind the future concerns for expansion. It might be that that practice is only going to be good for you for a couple years. If that's the case, then you need to factor in how much it's going to cost to refurbish that place. Because if you've spent tens of thousands of pounds refurbishing it, and you have to move out within 2 years, then that's kind of lost, right? You've got to make sure that it's got potential to grow in it without taking too much risk. The other concerns are legal, so asking, and make sure you do this before you set up, is asking the council for guidance before you start looking. Check the regulations for fireproofing, soundproofing, ventilation, fire alarm systems, all which need to be updated when you go for change of use. So if you have to convert an A1 to a D1, which is what you will do for a clinic, then the council will then make you abide by all of the up-to-date regulations. If you're taking over a shop that hasn't been updated in 20 years, you're going to then get hit with a lot of costs having to do it back up to modern standards, right? So FYI, you don't need any solicitors to oversee a contract which is 3 years and below, but you do need a solicitor for more than that. You want to make sure that you have a break clause and a rent review, and you you want to ascertain as to whether or not the lease can reduce during economic downturn, right? So our rent is quite reasonable, but for other practices, say if you're, for example, a big shopping centre, or if you're on Borough High Street, and then just like during COVID, everyone leaves the area, you want to make sure that you're not paying that top rent during that time. So you want to negotiate, say, well, the exposure has dropped a lot, I want to renegotiate my rent to reflect the economic downturn, can we do that? And it should be written into your contract to enable you to do that, yeah? And you can use the price per square foot to compare like for like, just like you do with any property. Make sure that you read the fine print. Contracts can be very sneaky. You want to opt for a self-containing lease, which means that you are not responsible for the roof or for the walls or for the structure of the building. Ideally not responsible for the electrics or the plumbing either, but that can be more tricky to negotiate. And you want to gain a survey of the premises beforehand if you want to be thorough to make sure that it's not going to fall down whilst you're in it. Any questions at all? All good?
No, that's like gold dust to know.
Oh really?
Yeah, like,
I'll definitely download the slides then.
Yeah, and this video.
Huh?
And the recording, will it go on?
Oh yeah, of course, yeah, of course, no problem.
How difficult is it to get everything your way on a contract? So
yeah, it's difficult, and it's not going to be something that the landlord's going to be experienced. It's not something that you're going to be able to, it's not going to be like something off of TV. You're like, no, I will have it my way, or I'm walking out the door, you never see me again. It's never going to be like that. It's going to be a dance again. It's going to be a negotiation back and forth. This is what I really want. I'm looking to be here for a long time. I'm a professional. I've got an established clientele. This is what I can bring here. I've got you stability. What are you going to give me in return for my stability? Yeah. Any questions at all? Okay. So this is the year that we expanded into the new clinic. So we can actually see here that a tiny number of our patients came through word of mouth, right? We've got 25% plus 11%, so it's only 36%. So just over 1 in 3 of our patients came through word of mouth. Very, very different to what you'd see for a lot of other businesses and a lot of other practices, right? And the reason why is all of this here, right? So we didn't have good SEO, so that's via pay-per-click for Google. Facebook, before we started to put money into it, that was about 2% of referrals. You put money into it, it's now up to 25%. Plus, I don't know if Instagram is there as well.
Just underneath on the right.
Next to Facebook.
Oh, okay, there you go, thank you. So it's 28%, so almost just under a third. Then got affiliation, so affiliation, building relationships with other clubs. And then we've then got the shop front, so that's about 10%, so 1 in 10 patients, yeah.
What sort of affiliation things did you set up, like gyms and stuff?
It's ongoing, always think that it being ongoing. So on our form, and I should be hotter on this, but this is what we've got on our form, is at the top of the form, is the question is this patient a member of any clubs which might benefit from our services, right? Now that could be Age UK, it could be a local badminton team, rugby team, football team. Now, the mistake that I made early on is I said, okay, cool, all of your team can now get a 10% discount. It doesn't work because they will mention it once and then they'll forget about it. What we now do is we say to them, we can give you a 10% discount on all of our services if you allow us to host a seminar for you on injury prevention and lifestyle. How much does that cost? Oh, it's completely free. 100% then will come down. And then so the other day we had a women's rugby team, came into the clinic, into the gym. We spoke about injury prevention, lifestyle, sleep, diet. We went through a demo treatment. And then we can then build a relationship where we could be their preferred point of contact. But I would definitely tie in something which builds rapport with them, give them gifts or something before you then agree to that affiliation discount, and then you'll start to see that growing, right? So let's have a look through here. So, so we've already explained this.
How do you gain all of this information? Are you?
Oh, this is on Clinico. Clinico?
Oh, you're doing Clinico?
Yeah, it's Clinico.
I love it.
I don't know what that is.
Oh, Clinico is a what do you call it? CRM, client relationships management software. You use Team 3 or Team 2?
We've got TM2.
TM2.
It's the same, right? Just
yeah, similar. Yeah, I really like Clinico. Lovely layout. It's very affordable, especially at the early stages, and it's just nice. It's nice to work with.
But you must be asking all of these people.
Yeah, how did you hear of us?
Right.
Yeah, so ask how did you hear of us, and then just put it on there. Yeah. Also, you ask how did you hear of us, and then Clinico then develops reports back off of that data.
Yeah, I can see that part happening. I just wondered how many questions you are asking these people as soon as they walk through the door.
Just
like, is it a bit of an onslaught of like, oh
no,
my God,
no. So it'll be like, what's your name? What's your address? Just out of interest, how did you hear of us? Boom, and then you come to this. That's it. All right. So, in my opinion, for social media, now especially, you must pay to have a tangible effect. When I first started using social media in 2013 to promote Revitalise, social media was still relatively novel. Not everyone was using it, but we were using it, and even still at that time, only about 2% of people came to see us. You start to put money into it, and then you get the 25% of people coming to you, right? Now, one thing I was going to mention with this, I can't remember, but I'll come back to it. All right, so you need to make sure that you structure your content on social media with good copywriting, good imaging, and good videography. I didn't pay anyone to do it, I just did it myself with a camera. Did you want to see a video actually? Do you want to see a promotional video?
Sorry, just a question.
Yeah.
What does the patient refer to?
Oh, this is just because we've got one for patient and one for word of mouth. So the patient will say, I just heard about you, that's word of mouth. The patient will say, this patient who's been to you before, referred you, and that's when we say patient. Yeah, let me show you a video. So this is one video which we did. And obviously you tell me what you think of it. But, see if I can find it. Oh, there we go. So this one here, this is one of the original videos that I did to publicise our services. So this one is majoritively responsible for the results that you saw on Facebook.
Passion got your business off the ground, but passion doesn't pay the bills. Customers do.
So what I'll do is I'll talk you through what I did and why I did it, right? So first of all, if this pops up on your Facebook, and you're like, I know that road, that's weird, he must be confident to stand outside in front of a camera whilst people are walking past. It kind of grabs people's attention, right? The other thing is you've got back pain, nerve impingement, these are pain points. So pain points grab attention, and you can use that to then spin an advertisement off of. Back pain, nerve impingement, tension headaches, shoulder impingement, these are things that you should be living with. Now, when I first opened the Revitalised Health and Fitness Clinic 4 years ago, my aim wasn't just to get people pain-free, but it was also to strengthen the engineers, make sure that they're not going to experience the same level of pain and frustration they did again. So, like, as you can see, the quality's not even that good, right? Like, you can hear the wind blowing and all of that. But what I'm trying to do is ascertain what the pain points are, and then what our philosophy is to dealing with those pain points and putting it across in a way that the ideal patient can relate to. I.e., we're not just going to get you pain-free, but we're also going to get you strong and stable again, right? 2,000 patients later, 2,000 square foot clinic, we're doing the exact same thing. So that's just testimony, that's just giving testimony to our success to say that we've got 2,000 patients and we're in a 2,000 square foot clinic, so we must be doing something right, yeah? Now what I'm going to do is show you a video of Sue and her testimonial. Now Sue came to me as a medical emergency. She had the worst category of back pain that you could possibly have. But with our help, with some treatment and exercises, 3 months later she was actually picking up 50 kilos from the floor repetitively during a deadlift in our training sessions. So once again, just quickly showing a patient from beginning to end and the potential of our treatments and our services, right? Especially a deadlift, because for a lot of patients with back pain that seems pretty unbelievable to be able to lift up 50 kilos, right?
Before Revitalise, I was crawling around the floor at home and having flown back from a medical emergency abroad, which they wanted to operate then, so I was pumped full of steroids, and then I contacted Elliot on recommendation, Revitalise. The MRI showed that I had 2 herniated discs at the bottom of my back. Literally, I was just a walking zombie. I couldn't function, couldn't do anything. I was so bad I actually couldn't get to the clinic, so he done
once again, and the interesting thing is actually paying attention to her hero story, right? Not mine, her hero story. This is a story about how Sue went from normal to then experiencing a severe downturn to then being even better than she was before, right? I.e. stronger than she ever was before. Now, because I'm focusing on Sue's hero story, the patient can then put themselves in Sue's position. If I focus on what I do and what I can do, the person can't view me and say, oh, I'm going to put myself in their position. They might say that's quite impressive, but they can't put themselves in my shoes, right? But they can put themselves in Sue's shoes.
Without any drugs, Elliot and I started to work at the gym, deadlifting weights, leg press.
Now, one thing that the patient might have, or the person viewing might have, is doubts, right? So these doubts and then their barriers to entry. So you want to address these barriers to entry as well. So one might be, well, that's just Sue. You might not be able to fix me, right? So now you have to start to compound and say, well, no, we fixed these people too. I know we've actually fixed another 1,998 people. So this is what we're going into.
And it's not just Sue in isolation. We've helped literally thousands of patients go from pre-surgery to pain-free with no
this is one of our favourite patients, Mrs. Thomas. She was going to have a knee replacement surgery, and within a few months we got her lunging and squatting, and we got her. She lost I think about 2 stone, and diabetes was better controlled, and yeah, she's very happy. She was very happy after.
Surgery at all. Mrs. Thomas, for example, helped her to avoid knee surgery, helped her to avoid a knee replacement. A few months later, we had her lunging. Ruth, for example, who has successfully avoided a hip replacement by coming to see us using our services. Even Paul Durso, who you might have seen, pays £500.
Oh, this is an interesting story. So I had a patient bet me on YouTube or on Facebook £500 that I couldn't help them. Ridiculous, right? So, but I treated him for free as long as he could let me film it, and then I got him after saying, "God, I feel so much better." So that's like, it's a nice thing to have. It's a bit funny, but also you're helping someone who's a bit of a doubter, right?
Did you get the 500 quid?
No, I said don't. I said let me record it instead.
Yeah. We couldn't get his back better. Got better after one treatment. He felt a lot better. And we didn't even keep him to the bed.
So once again, it's just built. And these videos, they're not as important. They're just showing what we can do. And then after that, obviously, you've got the call to action to book your free consultation today, right? It's win-win for the person. I've got nothing to lose. I'm only going to depart with my time. So I might as well give these guys a shot, right? Cool. Don't get me wrong. I wouldn't expect everyone to do that. I just did it because I like to do it, and I thought it was going to be effective, and I like learning about how to do it. You don't have to do that, but I'm just giving. You can do the same thing in writing. Yeah, with good copywriting, but that's just how I did it. Yeah. Okay. All right. Cool. So we've already covered. Yeah, so in here I've got details of how to write, or about writing attractive headlines, engaging content, call to actions. For the example here, YouTube is also a very good way to advertise. It's very cheap, but it doesn't allow people to comment or engage in the videos. One of the best things that you can have on the videos that you put on Facebook is, oh, I went to see so-and-so and they're fantastic. Oh, I went there too. Oh, did you? Yeah, I sent my son there as well. So you've got all of these comments underneath the videos, and loads of people like it, saying, yeah, they're doing a really good thing. That's also what helps to promote your practice. Whereas on YouTube, you can't really do that, right? Okay. So the other thing that we used was Google pay-per-click. So pay-per-click, you can, as soon as you open up an account and you start putting money into it, you can start to, you'll then be allocated an agent who will help you to grow your following, right? Or help you to grow your practice. We use email marketing 3 times a week, so our patients receive 3 emails a week that help them with their diet, or help them with their joint health, or help them with their mental health. So they get videos delivered to them from our practitioners, helping them, right? So it's a way that we can help our patients, provide value, but as well as that, it's another way that we can promote the services of the clinic. Okay.
Do you have nutritionists in your clinic as well, or dietitians?
So our personal trainers will help with diet when it comes to, say, weight loss or performance, and then for more pathological issues, that we've then got our herbalists who would provide bespoke dietary advice, and also herbs which might help with their management. But in terms of dietitians, we haven't got any dietitians. Yeah.
Regarding people that work for you, do you get every single one involved in marketing?
try to, or especially the ones that want to, or the ones that are quite good at it, because we all benefit by proxy anyway, so, or by association. Yeah. Cool. Any questions at all? Yes.
When you first started, was it only you that was starting as your business?
Yeah.
And like, how did you structure your planning of their progression, like in terms of?
Yeah. So the first thing you wanna, so yeah, it was
The way it's changed.
way it's changing.
Yeah, the way it's changed over the 4 years.
Yeah.
Because in terms of more people you brought in.
Yeah. So yeah, it was first just me starting. I quickly brought in a personal trainer and a sports therapist, because I thought that the personal trainer would be complementary, and the sports therapist then at that time worked as my overflow, right? I think the best way to look at it is you've got your North Star, which is where you want to go towards, and you're going to have to compromise to zigzag to get there. So it might be that, well, that's my North Star. I want a patient list of 2,000 people. And then you say, well, I need to get to that first 500, 1,000, 1,500, 2,000, right? And it might, so that's when you start experimenting. So you scatter your seeds and you see which grows quickest. Okay, I'm going to go for that one. Social media advertising and affiliate marketing, that seems to be working the best. You then get to that point and it starts to become a bit more interesting. You start to build a rapport. You can start doing more interesting things. You start doing raffles if you wanted to. Or you do like a riddle me this. So each Saturday someone gets a riddle, and the winner of the riddle, the person who gets it right, and then randomly allocated a number, they win a half-hour sports massage. You get more engagement on social media, stuff like that, but you need that following to be able to do that. And you can then start to tell more interesting patient stories from different perspectives of different practitioners. So yeah, I would say you're going to have to zigzag until you get there, essentially. Yeah.
I'm just wondering regarding like advertising like that, in terms of, I don't know if this is because the teacher that talked about sort of geos and regulations, stuff like that, regarding advertising, what we're treating and stuff.
Yeah.
But in my opinion, you really much scared us in terms of like.
Yeah, don't say you can do anything.
Yeah.
Because they're beyond you.
And even now, like, I don't even want to set up like a professional page because of like.
So this is the interesting thing. What did I say that I could do?
True.
I didn't say anything that I could do.
Yeah.
I said that Sue came here, this is what she experienced. Mrs. Thomas came here, this is what she experienced. So I'm telling their stories. When it comes to GEOS regulations, I'm very, very happy to sit inside that remit, because I only claim to be able to treat musculoskeletal conditions. I'm not saying that I can treat digestive upset. The only times that I get patients coming in with headaches is if they feel like they're cervicogenic and they're coming from the neck. So I don't have patients coming in with migraines that they had for a long time and want me to treat it. So we've built our reputation around what the evidence is showing us, and then obviously what fits into the GEOS remit is what we can treat. So I don't ever get into that that issue. Yeah.
But are you quite, I don't want to say structural, but osteopath, but in terms of like, do you not have like visceral or like cranial and stuff like that?
No, because the function of viscera is to deal with the gastrointestinal system, right? So I think a gastrointestinal specialist should be the one that deals with that. And you can have dietitians or nutritionists who are incredibly holistic with what they do, and that's a much better remit for them. Because what we've obviously found from research is that 98% of disc herniations are pain-free. 60% of individuals over the age of 40 have at least a grade 2 tear in the rotator cuff. So this idea of structure governs function as an osteopathic principle, I think is the weakest, at least in what we see and what we treat. Absolutely, if it was blunt force trauma, if someone had been in a road traffic accident, yeah, 100% structure governs function, fix the structure to improve the function. But with what we do, I don't think structure governs function is a principle which a lot of the time fits into the patients that we see. At least not in an anatomical sense, maybe in a physiological sense or even a psychological sense. Fantastic book by Suman Fernandez, who's a psychiatrist, wrote a book called Mental Health Worldwide, and he gives quite good evidence, suggests that even the chemical model of understanding psychology is out of date and out of touch. It's not there. When it comes to understanding depression or bipolar or borderline personality disorder or any personality disorder based on the chemistry of someone's brain, throw it out. It doesn't make concrete sense. It needs a patient-centered, holistic approach. Yeah. Cool. Any other questions at all? Cool. All right. So this next slide here this is how it's differed now, right? So what we've had, if we've gone from 25% or 36% word of mouth to now 9%, now it's 54% word of mouth combined, patient plus, when it was 36% before, right? Now, I've reduced spend on Facebook advertising to around 10% of what it was, and I don't spend anything on Google advertisements anymore. That's because our SEO is good enough that if people are looking for an osteopath, they will see that we are rated very highly and that we're at the top of the page. We don't need to compete on Google anymore. And the reason why I don't put as much money into Facebook anymore is because now that we've seen about 8,000 people, we've more or less reached saturation. So we don't need to consistently barrage people to come to us if they're in pain. We just need to gently remind them. Yeah.
That's a question.
Yes.
So just on how did it change on the sort of organic SEO that you get?
Yeah.
What things did you put in place to increase your sort of rating on Google and your?
Yeah. So I'll show you our website if you like. So.
Because obviously cost per click is quite costly.
It can be, but
and
it's worth it if there's an
SEO
ROI, right?
requires you to meet a load of algorithms for Google, right, to get on page 1.
If you were competing with the whole internet, but it's more likely that you're only competing with 5
Your
or 10
local
other
area.
Exactly that, yeah, exactly that. So if I go to our website, so there's a few things that you might be able to see. So this is based on the notion that people still like to scroll, right? So there's a lot of information, a lot of text on our pages, right? Now, it still navigates the patient journey. If they wanted a quick call to action, they can book an appointment straight away or get in touch, right? However, if they want more information, then the information is there for them. So this is just relating to what we're doing throughout lockdown. Once again, this is making sure that we're addressing a pain point for them. Is it going to be a clean, safe place? Then we've got a little bit of information here about what we can do. Saying that especially during lockdown that we are available online to help you as well. Had quite a lot. It was quite stressful. I had quite a lot of fun during lockdown because I was doing more online appointments, treating patients online from Australia, America, all over the country. Yeah, it's quite interesting. And then obviously you have to treat patients hands off, right? So you have to teach them how to treat themselves, and use exercise rehabilitation and addressing the foundations of the health to improve their rehabilitation or to enable to rehabilitate them, right? We've then got the different clinics that they can book into. So we'll go through the pain clinic in a second. This is a video just to make them familiar with what we're doing. You see multiple call to actions. They can see that we've been featured on MTV and we've won this award and that award. So it's just building our credentials, right? And then after that, you've got multiple testimonials, right? So if we focus on the pain clinic, so become pain free, using language that they understand. Our proven approach to your pain relief, providing them with aspects of information which break down any pain barrier or any pain points. Listing our credentials again, and you can see how from an SEO perspective, we are mentioning osteopathy, physiotherapy, sports therapy quite a lot, mentioning pain quite a lot. And using those things in combination with, say, the term Gravesend, it's then easier to list on Google.
You've got to get your keywords in your content. So
Yeah.
it picks you up.
Let's put it to the test. Let's type in osteopathic Gravesend. Yeah, so you've got, and this, so this is Bark. I don't even try on Bark. No, Bing. It's on Bing. I don't even try on Bing. But we're rated quite highly here. If we go to Google, I didn't even know that. That's good to know. Okay, so then if I type in osteopath, did I type in osteopath Gravesend last time?
Yeah.
Okay, that's good then. I thought I typed in revitalised Gravesend. So you've got this is an ad. This is an ad. Can't beat that. This is Gravesend Osteopaths, so because they've got Gravesend Osteopaths in their name, they're going to rank higher than us a lot of the time. But then bang underneath, we've then got osteopathy, physiotherapy, Gravesend.
How long did it take to get on that page?
It's just consistency. So the whole time we weren't appearing on it, I was paying to be on it, and then kept developing the website until we got on it, and then started to take money out of Google.
Yeah.
All right.
What's your turnaround? It's huge. That's terrifying. Yeah, what's your turnaround on the free consultation, how many
80%,
people?
about 80 to 90%.
Right.
Yeah, it's quite high. Yeah, patients a lot of the time, I think they're quite scared, they're quite concerned, and to be in front of someone, and also there's quite a lot of horror stories about, right, of people who have gone to osteopaths or chiropractors or physios and they whip them off, or they haven't done what they hoped them to do, and it just gives them 20 minutes where they can come in, they can have a chat with myself, I can diagnose them, tell them exactly what's going on and how we can help, and then get them booked in with a practitioner.
So you just do that for 20 minutes?
Just 20 minutes,
right,
yeah.
Okay.
Yeah. Sometimes it's online, most of the time it's face to face. Alright. Sorry.
How do you know? Do you know on average how many patients you treat a week?
Yeah, we did this calculation. 45 to 50.
You?
Yeah. So 45, yeah, on average it was 46, I think, 46 to 50. So I sometimes treat more. I work Monday 9 till 12, Tuesday 9 till 9, Wednesday 9 till 12, Thursday 9 till 12, Friday 9 till 8, and then Saturday 8 till 4. But that's not for everyone.
I'm just wondering because there's like a lot of work that goes into obviously building that clinic that you have, and there's a lot of employees and everything around it. That's what I'm just wondering.
Yeah, but you'll build your stamina as well. And also remember, you're gonna, as you graduate, you're gonna build your confidence. You're gonna be more certain with your approach, and you can be certain in uncertainty. You can say that it could be these 3 things. Let's go for this option. Let's tackle the other 2 later if I need to. Right? You're not then, oh, I'm not making the right decision. The tutor's on my back. I'm going to be upset. You haven't got to worry. It doesn't take as much mental energy. Yeah.
How long are your lists?
30 minutes for a continuation with a 5-minute grace, and then 45 minutes for a new patient with a 5-minute grace. Yeah. Unless they're insurance. If they're insurance, then sometimes it's 30 minutes for a new patient as well.
So all of this terrifies me.
Why?
I don't want to do all of that work.
You don't have to. You don't have to.
It takes me back to what I've left before.
Yeah, you don't have to.
Yeah. Oh my god.
Well, put it this way, right? And I think this is a nice way to think about it. This is all of the work that I've had to do to have to build up to a certain level of full-time and part-time income for 12 people. So if you're looking just to do it for yourself, you're talking about a fraction of the work in a fraction of the time. Yeah? Okay.
What was your motivation to sort of build this clinical empire rather than
clinical empire? So first off, that I really see the value in what we provide for people. We see people anyone who's earning, multiple tens of thousands of pounds a year to people who are on benefits. And the reason why is because we can make our treatment affordable to those people, and we give them a treatment which they can access quicker and is arguably more effective than if they were to go to, unfortunately, the underfunded NHS, which is a huge backlog and delays, right? So that's my main motivator. I'm very curious. I'm very curious of what could I do next, how could I improve that, how can I level up on what I'm already doing at the moment. So it's more me just fulfilling my nature. I've always been
just love it.
Yeah, I like seeing what's on the other side and just keep pushing it. Yeah.
Do you do like a lot of concessionary appointments and stuff like that to make things affordable for lower income? Or?
Kind of. So what we do is we offer unlimited support in between treatments. So because we're very much on empowering the patient, if we have a patient and they say, I can't come more than once every 2 to 3 weeks, then what we would do is say, okay, no problem, I'm going to set you up for the next 3 weeks. If you match this criteria, so for example, if you can do say you've got a patient with hip arthritis or, I don't know, like quadriceps tendonitis, something like that, right? We might say that after you've done a box squat, I then want you to try, so after you've done a box squat, sitting down and standing up, I then want you to slow it down the next week. And then after that, I want you to see if you can gradually just start to bend one knee like that. Obviously taking them through quite thoroughly. We give them videos as well to help them. And I say, if you get stuck at any point in time, if you flare up, drop me an email, give me a call, I'll coach you through it. So that's what we do for patients who can't come in as regularly. And to be honest, most patients don't ask for that, but I think that them just knowing that they can contact us anytime gives them the reassurance and the confidence to continue with that. Yeah. Cool. Any questions at all? Yes.
Do you enjoy this part of it?
Yeah.
Have you ever thought about like teaching or becoming like a clinic teacher or anything like that? Or is
Yeah,
that
a little bit. I spoke to Francesca, isn't it? I spoke to Francesca Wiggins.
Yeah.
But there weren't any places available. At the moment, I'm quite stuck for time, but I would definitely consider doing so. Yeah. And obviously, that's one thing actually. As part
of time, that's an understatement.
as part of the IO, I'm going to be speaking to the IO about this quite soon. Is I'm looking to start to do free classes on this type of stuff, because if you guys go out there and you are fantastic practitioners and you build the reputation of osteopathy, I am going to benefit anyway, and not just because I want to see osteopathy thrive, but your reputation will automatically elevate osteopathy to a level where more people hear about it, and then more people will be more likely to come to us as well. So we're not competing against each other as osteopaths. If we can level up the profession, then it will be a really good thing.
I think also regarding like evidencebased, we've talked about this. We're halfway through our 4th year and we've never discussed anything like this before.
Yeah.
It's just about what happens in the treatment room. It's not about how to get there.
Yeah, and it's very important because, and this is one thing which I don't know what your years are like, but I didn't notice this until after university, that a lot of my colleagues, which isn't a bad thing, came from quite privileged backgrounds, right? Which meant that they could kind of really take their time figuring it out, whereas I couldn't. I needed to make sure that my overheads were covered quite quickly. That's quite scary for people coming from backgrounds where they're not as supported, because they can't go into a profession with unsure career progression and then try and smash it after they've graduated with a load of student debt. So the issue is that, once again, without that exposure of the profession, it hinders all of us. Because the other thing and this is why I like the idea, or I think equality of opportunity is so important, is that I don't want to be competing against people who are just lucky enough to be in the same position as me. I want to compete against the best possible. And it's important that we try and source osteopaths from the best possible, not best possible places. We source the best possible candidates to be osteopaths. So yeah, that's why I think it's important as well. And that's why it's important that we are as effective as we can be. Any questions at all? All good? Alright, sweet. Almost done. So, I think we are done.